According to UNAIDS in 2021, 96% of PL-HIV were 15 years and older, and 54% were women and girls. Of 1.5 million new infections, key populations and their sexual partners accounted for 70%, and women and girls comprised 49%. Sexual transmission continues to be the key mode of spread. HIV upfront means to look at diverse sexual behaviors with eyes wide open, underscoring the sexual vulnerabilities of LGBTQI, but also of women and young people. It will also elaborate on the harm of stigma and the increasing criminalization of sexual behaviors. The hope is that health providers would become more comfortable, positive, and respectful of diverse sexualities. Let me begin with a description of diverse sexual behaviors. Popovich in 2006 professed that psychosexual diversity is the best representation of human normality across cultures. Among his observations then were that masturbation increased, particularly among the better educated and those afraid of HIV. Oral and anal sex increased. Majority of the general population remained heterosexual, but many remained bisexual, and some remained strictly homosexual. 13 to 14% of heterosexuals have had anal intercourse, and 20% or more avoid sexual activity. He wrote that sexual expressiveness still appears to be greatly influenced by values, prejudices, conformism, secretiveness, and hypocrisy, and he concluded that there is not one universal, but rather multiple normalities, and that a broad psychosexual normality is socially and politically and value-based rather than a rigorous scientific category. The first part of my talk will deal with various sexual orientations. Heterosexual men and women are the most likely to have had sex only with other sex partners. Heterosexuals in monogamous relationships are at low risk for contracting HIV, but studies show that both partners could have had previous sexual contacts with partners who could have been infected. Most cases of HIV transmission in these couples are male to female from the men's past high-risk sexual contacts, including with same-sex partners and sex workers. Differences in sexual behavior between men and women, combined with a relatively higher efficiency of HIV transmission from male to female, result in men having only 5%, but women having 33% HIV infection from unprotected heterosexual sex. Heterosexuals, especially the men, have sexual behaviors similar to gay men. About 75% of heterosexual couples engage in oral sex, same percentage reported in male homosexual couples. Many heterosexual couples also practice anal sex, although not as frequently as homosexual couples. These data also support the need to focus on all types of sexual behavior in order to prevent HIV infection. Gay men and lesbians are the most likely to have had sex only with same-sex partners, and their practice is as varied as that of heterosexuals. Traditionally, typical behavior for gay males include mutual masturbation, full body contact, oral genital sex, and anal sex, in descending order of popularity. Gay women typically use clitoral stimulation, oral genital sex, and anal and vaginal penetration. Bisexuals engage in romantic or sexual relationships with more than one sex or gender. In 2016, the US CDC reported that 1.3 of American women and 1.9 of American men said they were homosexual, gay, or lesbian, and 5.5 of women and 2% of men said they were bisexual. These findings indicate that bisexual may comprise the largest single group in the LGBTQI community. Among transgenders, sexual behavior refers not only to sex with another person through coitus or mutual masturbation with or without objects. It also refers to associated behaviors such as hiding one's genitals or not allowing one's partner to touch them. A 2014 study indicated that prior to gender reaffirming treatments, trans women and trans men did not differ in the involvement or avoidance of their genitals in sexual relations and their experience of genital sensations during sexual contact. However, a 2021 study showed that more trans women practiced penetration, both insertive and receptive, using genitals and sexual toys, compared to trans men who did not penetrate or were not penetrated. Across these different sexual groups, sexual orientation and identity is strongly, but not always, associated with whether men and women have sex with women, men, or both. Heterosexual men and women are the most likely to have had sex only with other sex partners. Bisexual men and women are the most likely to have had sex with both women and men. And gay men and lesbians are the most likely to have had sex only with same-sex partners. Patterns also differ between men and women. Women, both lesbian and straight, were observed to be more flexible with either their identities or behavior than men. For example, in the year prior to the study, heterosexual women were more likely than heterosexual men to have had sex with women, and lesbians were more likely than gay men to have had sex with an other sex partner. I will now go into the sexual behavior and vulnerabilities of women and youth. Looking at sexually transmitted infections, women are impacted more than men by sexually transmitted infections, biologically and socially. Biologically, their sexual anatomies enables more efficient transmission from men to women. Women are less likely to have symptoms and therefore tend to seek help later. Moreover, women face more serious consequences, such as long-term pain, cancer, and infertility. HIV studies show that 49% of women and girls are infected predominantly via heterosexual transmission, where they are the receptive partners in anal or vaginal sex, without protection or HIV prophylaxis. What about the sexual vulnerabilities of adolescents and young people? Sex is a part of many adolescents and young people's lives. In adolescence, driving factors towards sexual initiation include biological sexual maturation, parent and peer values associated with sexual behaviors, and the adolescent's own sense of self and interest in sex, plus environmental opportunities for engaging in sexual intimacies. In the order of frequency, adolescent sexual behavior can range from abstinence to masturbation to different types of sexual intercourse, including outercourse or non-penetrative sex, and also cybersex or sexting through the exchange of sexually explicit messages and images. Dramatic changes in the sexual behavior of young people in recent years are attributed to lifestyles propagated in social media and the web. The effects are earlier sexual initiation, sex before and outside marriage, and diverse sexual orientations and relationships. Although there is an apparent convergence in the sexual behaviors of young men and women, researchers say that the convergence is not the same as gender equality. This is because of the persistence of gender stereotypes and sexual double standards, and the pervasiveness of sexual coercion and abuse of women. People in their teens and early 20s are at risk of contracting STIs and HIV because of biological, behavioral, and socio-economic cultural reasons. Adolescent girls and young women are more susceptible to STIs and HIV biologically, and because of their inferior social status. Young men who have sex with men are at very high risk because of stigma and their sexual networks. And young sex workers are at very high risk too because of multiple sexual partners and their inability to negotiate condom use. I will now talk about sexual stigma and the criminalization of sexual behaviors. Sexual stigma refers to the negative regard, inferior status, and relative powerlessness that society accords to any non-heterosexual behavior or attribute or related condition. 5 types of stigma are described. First, enacted stigma, which refers to overt actions such as the use of anti-gay epithets, shunning, and ostracism of LGBTQI individuals. Second, experienced stigma, which refers to the explicit experience of poor treatment on the basis of specific characteristics. Third is perceived stigma, which refers to the belief that individuals or societies treat people differently due to a stigmatized characteristic. Fourth, anticipated stigma, which is the fear or expectation of stigma or discrimination. And fifth, internalized or self-stigma, which refers to the acceptance of stigma as part of one's own value system and self-concepts. One aspect of sexual stigma is the stigma on STIs and HIV/AIDS. Persons with STIs and HIV often experience embarrassment, shame, isolation, and rejection that result in feelings of fear, anxiety, and low self-esteem. Stigma makes people fearful of losing family support and other social entitlements, which makes them reluctant to disclose their conditions. Stigma towards gay populations has been linked with adverse HIV-related outcomes. Among MSM, for example, perceived and experienced stigma has been associated with increased fear and avoidance of seeking health care, having condom-less anal sex, and reduced rates of HIV testing and seeking services. Sexual stigma intersects with other structural factors like poverty, gender discrimination, and other marginalization to keep life-saving information and services out of reach of the people who most need them. Stigma and criminalization combine to create a hostile environment for HIV intervention. Criminalization of sexuality, according to Amnesty International, is when consensual sexual actions and decisions or the expression of sexual and gender identities is restricted or punished. The following are examples of criminalized sexual behaviors more widely. Number 1, consensual sex between men and sometimes between women. This constitutes a criminal offense in 71 countries worldwide. Legal justification is usually by reference to religious doctrines or morality. Beyond penalizing homosexual acts, the laws also result in stigmatizing, policing, and punishing people whose sexual orientation or gender identity does not conform to the strict sexual norms. 2. Criminalization of HIV-related behaviors, such as PLHIVs allegedly passing on or exposing others to HIV. Justification is usually the need for state to deter or punish cases of deliberate and malicious HIV transmission, or to promote disclosure as an HIV prevention measure. Research, however, has failed to demonstrate any positive impact of criminalization on HIV prevention or on the behaviors of people living with or at risk of HIV. In fact, criminalization could further discourage HIV testing and disclosure by promoting fear and resistance to being tested and therefore diagnosed. Criminal prosecutions have also contributed to stigma and discrimination against people living with or affected by HIV. 3. Criminalization of adolescent sexual activity, particularly sexual initiation. Most states set an age at which adolescents are deemed legally capable of consenting to sex. The age of consent, which could be as early as 14 and as late as 18. Justification cited is the protection of girls against sexual violence, particularly rape. However, age of consent laws can and have been used to deny young people's right to make decisions and to access sexual and reproductive health information and services. The CEDAW Committee, the Committee of the Women's Convention, has expressed concern that the penalization of consensual sexual relations among young people between 15 and 18 years of age may have a more severe impact on young women, especially in the light of persistence of patriarchal attitudes. 4. Criminalization of sex work, whether sex work as a whole or of certain activities, such as the purchase or facilitation of purchase of sexual services. Sex work may be done as a choice or preferred means of earning a living. However, it can also be the recourse of people who have limited options due to poverty and marginalization. Criminalization does not support individuals to overcome poverty. In fact, criminalization could further exacerbate socio-economic marginalization, compromise sex workers' protection from abuse and violence of clients, and expose them to abuse by law enforcement people themselves. Criminalization of sex work also promotes and perpetuates negative attitudes towards sex workers by stigmatizing them, thereby impeding their access to basic social and health services. Criminalization also gives law enforcement officials and indeed communities license to treat sex workers with contempt, to harass, threaten, extort, and in some cases subject them to violence, including sexual violence. The Lancet, in July 2014, stated that of all potential interventions identified for HIV, decriminalization of sex work would have the greatest effect on the course of HIV epidemics across all settings, averting 33 to 46% of HIV infections in the next decade. So how should health workers respond more appropriately and effectively to HIV in our particular settings? I have adapted the 7 recommendations of UNAIDS in the 2020 report, We've Got the Power, Women, Adolescent Girls, and the HIV Response. Number 1, acceptance of the wide diversity of sexual behaviors and respectful and dignified care of LGBTQI, MSM, sex workers, young people, and people living with HIV. 2, decriminalization of issues related to sexuality and HIV, and cracking down on stigma, discrimination, and violence, especially in communities and healthcare settings. 3, fully functional healthcare facilities that are affordable and accessible to the most marginalized, including LGBTQIs, where the staff are adept in clinical and socio-cultural skills that deal with diverse sexual behaviors. 4, comprehensive sexuality education framed by positive sexuality and respect for sexual diversity throughout the life cycle. 5, integrated HIV and sexual and reproductive health services that promote gender equality and human rights, sexual pleasure, and respectful relationships, regardless of sexual identity, gender orientation, and HIV status. 6, incorporating peer support in HIV treatment and care services. And finally, 7, active involvement of key affected groups in policy making and in developing and providing leadership for HIV and AIDS programs. Only with positive sexuality and respect for sexual diversity can we appraise the problem of HIV clearly and address it most effectively. Maraming salamat po.